Senior Consultant of Neurology at St. John's Medical College, Bangalore, and he's a retired Senior Professor from NIMHANS. Of course, he needs no introduction to all of you because so many of you have graduated from NIMHANS and you would know how popular his classes of movement disorders in NIMHANS have been. I am a pediatric neurologist and it has come, I have known Sir. So with that introduction of Pramod Pal sir, we thank him for giving us his time on this Sunday morning and sharing his knowledge and clinical experience with us. Thank you, sir, for joining the YNF session. I invite you to this session.
Thank you, Josna. Thank you.
We also have senior moderators who have, with their clinical experience, have trained the residents in doing these presentations. And Dr. Atif Sheikh, he's a professor in the Department of Neurology at Christian Medical College, Vellore. And we have Dr. Tony Varghese Panikkar with us, Associate Professor in the Department of Neurology at CMC, Vellore. I invite wholeheartedly Dr. Atif and Dr. Tony Varghese for giving us your time and also supporting the residents in giving their presentations. Welcome, Dr. Atif and Dr. Tony.
Thank you. Thank you.
Thank you. Having some laptop problems, so I'm joining with my phone. And just to tell everyone, we are from the Department of Neurological Sciences, and I am from the Neurosurgery Department. So we can start off with the presentation. I think Jennifer is
Ready.
Ready.
Dr. Atif, could you please introduce
Just
the resident?
thanks, Pramod sir. Pal sir is, of course, a brilliant teacher, phenomenal leader, not just in our country, but also in the whole Asia-Oceanic region and indeed the world. He's well known for his studies, teaching, and research. We have two residents from our department, Neurological Sciences. Jennifer is a resident in neurology. She'll be presenting the clinical details of the patients. And after that, Vimal Brito, he will take over to the surgical aspects of the presentation. Without wasting time, we'll go on to the presentation.
Good morning, everyone. I'm Dr. Jennifer, Senior Resident in the Department of Neurology, and I thank everyone for giving me this opportunity. I will be presenting two patients that we had taken care of. The first patient, I'll call her Mrs. J. She's a 63-year-old lady, a housewife from Tamil Nadu, who presented with tremors for the past 4 years and slowing of activities for the past 4 years. The tremors were asymmetric in onset, which started first in the left upper limb around 4 years ago, and later, 2 years later, involved the right upper limb as well. These tremors were maximal at rest and decreased during voluntary movement and disappeared during sleep. However, the intensity of the tremors has increased over the past 4 years, and her current tremor is disabling, affecting her activities of daily living. She also had slowing of activities, which the family noticed as her taking longer time to do her usual household activities. This was also associated with progressive walking difficulty. However, there was no history of limb weakness, sensory symptoms, or gait imbalance. Apart from the motor symptoms, she also had occasional constipation and occasional insomnia, but there was no history of dream enactment behavior suggestive of REM behavior disorders. There was no history of recurrent falls, no history of memory disturbance or cognitive decline. There was no history of hallucinations, no alien limb phenomenon, no speech or swallowing difficulty. Her other comorbidity, she was also a known hypertensive for the past 10 years and has been on amlodipine 10 mg once daily. She had no family history of tremor, Parkinson's disease, dystonia, or other neurodegenerative disorders. For these complaints, she was on medication since 2023. And her current medications included Syndopa Plus 125 mg thrice daily, Pramipexole ER 0.375 mg twice daily, and trihexyphenidyl 2 mg twice daily. The levodopa equivalent daily dose came up to 405 mg per day. I will shortly go into how this was calculated. So after taking these medications, she reported that the tremors and speed of doing her activities improved around 20 minutes after taking the Syndopa, and this improvement lasted for about an hour. There was no history of troublesome dyskinesias. Coming to what is LEDD, or the levodopa equivalent daily dose, it is defined as the total daily dose of dopaminergic medications expressed as equivalent dose of the immediate released oral levodopa, calculated using validated conversion factors. So this is a calculator for determining the LEDD. This calculator is available online, and what we have to do is enter the daily dose of all her dopamine containing medications. So this includes the immediate release, controlled release, and extended release levodopa, along with the entacapone, tolcapone, or opicapone combinations, also including rotigotine, ropinirole, pramipexole, rasagiline, apomorphine, and amantadines. So for this particular patient, her LEDD was about 405 mg per day. Having said that, there is no standardized cutoffs. However, a lot of studies that have looked at LEDD have taken a dose of more than 800 to 1000 mg, which is suggestive of advanced Parkinson's disease. On examination, her heart rate was 88 beats per minute. Her blood pressure in supine position was 190/100. There was no orthostatic hypotension. General examination was normal. She was conscious, awake, alert, and oriented. Her higher mental functions was normal. She scored 30 points on her MOCA examination. Cranial, cranial nerve examination was also normal. Extraocular movements were full and complete, and saccades were normal. On examination of the motor system, um, examination of the tone revealed no neck rigidity. However, there was cogwheeling rigidity with activated rigidity present in bilateral upper and lower limbs. On examination of bradykinesia, finger tapping was impaired. Left was more impaired than the right. Repetitive hand opening was impaired, along with impaired toe tapping. A resting tremor was noted bilaterally, left more than right. High amplitude tremors were noted. She also had a postural tremor noted in bilateral upper limbs, along with re-emergent tremor. However, there was no jaw tremor or titubation. On examination of her gait, arm swing was reduced. There was no postural instability, no freezing. Cerebellar signs and pyramidal signs were negative. On examination of a UPDRS Part 3, which I will describe in detail in a bit, on her on stage, she scored 45 points, and in the off stage, she scored 45 points, and in the on stage, she scored 28 points. And her percentage levodopa responsiveness came to 37.7%. I will again go into how this was calculated and why it's relevant. After the levodopa challenge, bradykinesia and rigidity improved, but the tremor did not improve much. Her CRST rating for the tremor was 48 out of 144. This is the video of her examination findings. What we're seeing now is that she has a resting tremor bilaterally, both on the right side and on the left. The amplitude is frequency is about 8 to 10 hertz, high amplitude tremors. Postural tremor was also noted. These were predominantly rest and postural tremors. There was no intentional tremors that were noted on examination. So, summarizing this patient, she was a 64-year-old lady who had presented with asymmetric onset tremor starting in the left upper limb, later to involve the right upper limb as well, with disabling tremors affecting her ADLs. So, clinically, idiopathic Parkinson's was diagnosed with a tremor predominant phenotype. Just a short note on the UPDRS part 3, which is the motor examination. The first part of this examination includes we have to assess first if the patient is on medication for treatment of Parkinson's, and if the what is her current state. If the patient is receiving medication for treatment, we have to mark whether she is currently on or off. On is basically the functional state when the patients are receiving medication, have a good response. Off is the functional state when there is poor response in spite of taking medications. And also we need to check if the patient is on levodopa. If yes, what was the how many minutes since the last levodopa dose? So the components, it includes about 18 components, the UPDRS part 3, the motor examination, which includes the speech, facial expression, rigidity involving neck and appendicular, finger tapping, hand movements, pronation and toe tapping to assess for bradykinesia, leg agility arising from chair, gait, which looks at the stance, freezing, postural stability, along with the tremor, postural tremor, kinetic, and the rest tremor amplitude. All of these are graded, and a final score is added. After doing the part 3 of the motor examination, they are also classified by the Horn and Yar staging. 0 is asymptomatic. 1 indicates unilateral involvement only. 2 indicates bilateral involvement without impairment of balance. 3 includes mild to moderate involvement with some postural instability, but they're physically independent. 4 indicates a severe disability, but still able to walk or stand unassisted. And 5 would indicate a wheelchair bound. In this case, our patient would fall into Horn and Yar stage 4. The other clinical rating, or rather clinical tool that we can use to assess the tremor is the CRST. The CRST comprises of 3 parts. Part A, to to assess for severity. Part B, where we look at specific motor tasks, and these tasks include handwriting, spiral drawing, and pouring water. And part C, which looks at functional disability, the impact on daily living, like speaking, dressing, hygiene-related activities. So the total score is, maximum score is 144, and the higher the score, the more severe the tremor. Our patient had a score of 48. The other thing I had also mentioned was the levodopa responsiveness. It is defined as the clinical improvement in symptoms like bradykinesia, rigidity, and tremor following the administration of levodopa. How this test is done is that around 12 hours prior to the test, we withhold all the dopamine containing medications. Following this, UPDRS part 3 off state score is noted. After this, a supratherapeutic or supranormal dose, about 2 times the standard dose of levodopa carbidopa, is administered. Following the administration of levodopa, the patient is monitored for about 45 to 90 minutes to allow the medication to reach peak concentration. After this, the UPDRS part 3 on state score is calculated. So interpretation of the levodopa responsiveness score, it is calculated as a percentage of score minus the peak on score divided by the off score. So a result of more than 30% improvement indicates a positive response to levodopa. As we calculated for our patient, it was about 37% in our first patient. We'll now look at our second patient, Mrs. A.
Can I interrupt here? Is
Yes.
it Saraswati?
Yes,
Is it
sir.
okay
Yes, sir.
from
Yes, sir.
team?
Yes,
Yes,
sir.
sir.
Yeah. So I think the presentation was excellent. And coming to the last point, what you mentioned, so apart from withholding the 12 hours, that is only for the immediate release. Okay. But if a person is taking a control release preparation or a dopamine agonist, you have to withdraw for at least about 18 hours. Okay. So
Yes.
this is the protocol we follow, that you should, because this patient was getting dopamine agonist, CR,
Yes.
etc. So this has to be withheld for 18 hours. This is number one. Second thing is that sometimes not in this particular patient, but in sometimes we find that even if you withdraw for 18 hours, the patient says that I'm not that off. Okay. And I am much worse when I'm in the house or something. So in those cases, maybe sometimes if you have a way to observe the person, you can withhold medicines for further longer time to get the worst off, because this will help in the documenting if you're doing a DBS or any other things, the worst off and the best on. So sometimes what happens is that, and about 1.5 to 2 times the standard dose, we use that if but in general, we give about either the 2 tablets of 125 milligram levodopa carbidopa or a the maximum dose what the person is taking if it is above that 2 tablets. Now, what happens is that after one understand, you are telling that you see after 45 to 90 minutes. But sometimes this may not be relevant, but you have to wait for a little more time and see when is the best on. So we go for the worst off and go for the best on, and then we see this. And I don't think you have mentioned much about the dyskinesia. So this also we note down when we do the levodopa, test or the off state and on state, because dyskinesia is also important to monitor before you go ahead with a deep brain stimulation, etc. This is number one. Second thing, in your video, I'll give it to Ella very soon. In your video, you have documented correctly, but one or 2 points you need to document is the voice tremor, is okay, voice leap when the patient is talking. Second thing is that you mentioned about very severe tremor, but in general, in Parkinson's disease, you will not get about 10 hertz tremor. Okay, so it appears that the hand is shaking like this, but if you record it, it is not 8 to 10 hertz tremor. Is very unlikely. The amplitude is very high, but the tremor is about 4 hertz or 6 hertz, is not more than that. And other thing is that later on, I think you have mentioned something. When you look for a re-emergent tremor, that you have to demonstrate in the video, you keep the hand for some time, then lift the hand, wait for about 10, 15, about 8 seconds, and then see whether it is emerging or not. But if you want to really document these areas of tremor, you should do it. And one more thing is that your documentation, you may have done it, the handwriting. So handwriting in a person is one thing to look for micrographia, which is very well brought out, because these may be standard procedures before you do a intervention. And another thing is that the tremor, the handwriting will bring it out. So there are the few things, maybe you are doing it, you have not shown it, but these are very important. Yeah, I'll give it to Ella
Yes, sir.
to maybe some comments. Yeah.
Thank you, sir. So regarding the Levodopa response test, I think Pal sir has brought out some of the points, but there are certain things that we need to note. So what you have said 12 hours prior, so that is called the defined off state. Whenever we are doing Levodopa responsiveness, especially in the context of device-assisted therapies, the protocol that we use is called the CAPSIT protocol, in which it says 12 hours off, irrespective of whether the patient is taking dopamine agonists or whatever medication, extended release medications, it is just 12 hours off. So, so we need to also say which protocol we are following for doing the levodopa responsiveness test. And as sir rightly pointed out, sometimes the 12-hour off may not be representative of the worst off of the patient. But for the perspective of surgical interventions, the 12-hour off and 33% reduction after dose of levodopa, that is what is considered to be the cutoff marks for the for deciding for device assisted therapy. And regarding levodopa administration, when we say 1.5 to 2 times the standard dose of levodopa, are you meaning the levodopa carbidopa alone or the levodopa equivalent daily dose that is being administered, the habitual levodopa equivalent dose? So what
The
did
hab
we do in this patient?
the habitual levodopa dose, ma'am.
Just the levodopa dose, right?
Yes, ma'am.
So, I mean, when the patient is already on 2 pills, so what is the maximum dose? Is there any cutoff or anything that you follow? Like if the patient is on 3 pills, 3 pills
Yes.
of levodopa,
Yeah.
then what is the maximum dose that there is?
Mm.
So
It's
actually,
all, what Ella is saying is correct, but it all depends on where you are setting up a protocol. Okay. And by and large, wherever we have done earlier, you told about the capsid is okay, but if it is a control release or a extended release preparation or a agonist, we used to always, even in Vancouver, Toronto, we have used a word at least for 12, 18 hours, we put them off. Okay. And here the best dose, if the person is taking 300 milligram, we usually give 300 milligram. So at least it has to be 200 milligram, but it has to be if the patient is taking more than that, we have to give that dose. Okay. Otherwise, we are trying to see at the baseline what is the patient status. Okay. The worst off, the best on. So this is the way, but it all depends on the place where you're working and what you are laying down as the norms for your this. So this is my comment on this area.
I agree, sir. I agree completely because there are certain institutes, especially in the Western world, the patients are being called for doing the on-off assessment during the OPD hours. They are not admitted. So in India, we have the luxury of getting the patients admitted, and if the patient is admitted, you can do 18-hour off or 20 hours off. But for patients who are coming into the OPD for doing the off-on assessment, it may be very difficult for the family to put the patient off medication for 18 hours. So that is something which we may have to keep in mind because again, putting the patient off for 12 hours or 18 hours just for the purpose of doing the off on assessment may not be
No, no, not for the purpose
feasible.
of it. Only when you're thinking of a DBS or you're taking intervention, it's only one time. So that is the purpose we are telling. Otherwise, casual off and on in the OPD setting is enough. Worst off and the best on, it is enough actually. I think we can proceed maybe further. Yeah,
Yes, sir. So
yeah,
basically, it's at least 12 hours, and as
at
sir
least 12.
said, we
Yeah.
can go up to 24 hours also, and we have done that in some patients. And the most important part is whatever you follow, we have to document. So how many pills were given, how many pills patients were taking, the documentation is very important.
Yeah, we can proceed maybe. If there are any other questions regarding the first patient,
No, sir. No other questions. Yes.
I think then we can go ahead with the second. Maybe it's already half an hour. Yeah.
Yes, sir. So our second patient, we'll call her Mrs. A. She is a 47-year-old lady who is a housewife from Tamil Nadu. She presented with slowing of activities for 15 years. So symptom onset was since around 32 years of age, with progressive walking difficulty for the past 15 years and involuntary movements involving bilateral upper and lower limbs. The first symptoms that her family noted was slowing of activities when she had started taking longer time to do household activities along with her farming activities. This was also associated with progressive walking difficulty, where she had difficulty in initiating steps and inability to move forwards after taking a few steps. She also started having forward falls around 2 years after her symptom onset. She was started on Syndopa for these complaints, following which there was some improvement in gait. However, after around half an hour of the Syndopa intake, she had involuntary movements of bilateral upper and lower limbs. Uh, Coming to her non-motor symptoms, she had occasional constipation and sleep disturbance. Her current medication list included Syndopa Plus 125 mg 6 times a day, Syndopa CR 125 mg once daily, trihexyphenidyl 2 mg thrice daily, and amantadine 200 mg once daily. So for her, the levodopa daily dose came up to 844 mg per day. Her other comorbidities included that she had a congenital acyanotic heart disease. She had an atrial septal defect for which she had undergone device closure in 2018. On examination, heart rate was 88 beats per minute. Supine blood pressure was 120/70 millimeter mercury, and there was no orthostatic hypotension. On CNS examination, she was conscious, awake, alert, and oriented. Her higher mental functions were normal. She scored a MoCA score of 28. Cranial nerve examination was also normal. Coming to her motor system examination, uh, axial rigidity was present. There was neck rigidity was present, along with appendicular cogwheeling rigidity with activated rigidity of bilateral upper limbs and lower limbs, which was more demonstrable on the right side. There was evidence of bradykinesia in the form of impaired finger tapping more on the right side, impaired repetitive hand opening again more on the right side, and impaired toe tapping. Rest tremor was present with no postural or kinetic tremor. In the on period, she had dyskinesias involving both the bilateral upper and lower limbs. And the UPDRS part 3 on the on period was 35. During the off period, she had freezing of gait with fascination and turn hesitation, and her UPDRS part 3 score was 34. This is a video demonstrating her dyskinesias.
Is the patient is she having a mask? Why she's not
That was
lying
her
on a bed?
That was her pre-procedure video, sir. She was just being taken to theater for the scalp block.
Oh, okay. You didn't do it before, means few
We
days before that, no?
we have done it, sir. Just the videos are not available.
Okay.
So clinically, her diagnosis, she was diagnosed with young onset Parkinsonism with motor fluctuations, with levodopa induced peak dose dyskinesias, possible syndromic in view of young onset. She also had a congenital acyanotic heart disease with an atrial septal defect post ASD device closure in 2018. And her X-ray spine, on her X-ray spine, she also had cervical hemivertebrae. So summarizing our two patients, our first patient that we had seen was an idiopathic Parkinson's disease with a tremor predominant phenotype. And the second patient that we had seen was a young onset Parkinsonism with motor fluctuations and levodopa induced peak dose dyskinesias. So both of our patients were on high doses of levodopa daily dose equivalents. So in patients like these who are already on high dose levodopa daily dose equivalents with uh, disabling tremors affecting their ADLs and peak dose dyskinesias, when would you consider an advanced therapies in Parkinson's? So there are a few screening tools that are available. The simple screening tool is the 5-2-1 tool. 5 if they're taking more than 5 times per day of oral levodopa, or if they're in the off period for more than 2 hours per day, or if they're having more than 1 hour per day of troublesome dyskinesia. Another screening tool is called the Manage PD tool, where there are 3 sections. The first section is to screen for inadequate control on current oral medications. So the questions we need to ask is, are they taking oral levodopa more than 5 times per day? Are they having more than 2 hours of off time per day? Are they having unpredictable fluctuations of motor symptoms? Are they having troublesome dyskinesias? Or are they having limitations in more than one ADLs? If the answer is no to any of these questions, the patient is classified as category 1 and we can continue medical management on those patients. However, if the answer is yes to any of these questions, then we proceed to the next set of questions. So the next set of questions we're looking at is to determine eligibility for evaluating device-aided treatment for for symptom control. So if they have unpredictable motor fluctuations, off time periods, troublesome dyskinesias, freezing of gait during the off time, significant ADL impairment, falls within the past month, non-motor off symptoms, hallucinations, psychosis, and dystonia with pain. If any of these are present, which is higher than the established threshold, then they are eligible for device-aided therapy. So what are the advanced therapies that are available? I've just classified them as device-assisted therapies and ablative procedures. In the device-assisted therapies, there is DBS or deep brain stimulation, which is widely used. The other upcoming therapies are intrajejunal levodopa-carbidopa infusions with subcutaneous apomorphine infusions. The other ablative procedures are RF radiofrequency ablation and the MR guided focused ultrasound procedures. So in our patients, because they had indications for requiring a higher advanced form of therapies for the Parkinson's, our first patient underwent MR guided focused ultrasound to the left VIM nucleus. And our second patient, although she was an ideal candidate for DBS in view of younger age, and she was counseled regarding the same, but had not consented for it, she underwent an MR guided focused ultrasound procedure to the left pallido-thalamic tract.
So
Just
just
one second before, can you
yeah.
go back to the slide where indications, there's some discussion. Sir, you want to take this one, sir?
Yeah, just 1 second before that, Jennifer, can you go back to the final drugs? What the second patient was taking? What was the,
Yes, sir.
yeah. So, okay, so 125 milligram 6 times here, trihexyphenidyl, amantadine. So I just wondering that, so in this scenario, forget about what type of procedure you will use. So there is a 15 years history of this young onset or early onset Parkinson's disease patient. You had mentioned that she started having falls within 2 years. Now, you have documented the off and on nicely, but I think the dyskinesia rating and all these things should also be documented. Second thing is that ideally, if the patient does not have any contraindications to dopamine agonist, like impulse control disorder severe or psychosis or postural hypotension, I would have started, or many of us would have started the patient on a dopamine agonist. So I do not know why the dopamine agonist has not been, because the moment a person develops a dyskinesia and is only on levodopa carbidopa, then it is the next step may be to reduce the levodopa carbidopa, stop the CR preparations and start on a dopamine agonist. And at least the prime pace you can go up to 1.5 milligram 3 times a day, or ropenolol up to about 16 to 20 milligram. Amantadine is right drug to give, but again, I will not give trihexyphenidyl in any of these patients, even if it is a tremor predominant, because the long-term side effects are quite bad in these patients, and particularly this patient did not have also much of tremor. So dopamine agonist should have been tried in this patient unless there is a contraindication to not give dopamine agonist before we contemplate for a surgical treatment in these patients. Yeah,
Yes, sir.
Atif?
Yes, sir. So it was mostly a financial reason.
Okay, yeah,
They could not afford it. That's why
fine.
actually trihexyphenidyl also, she was getting some hallucinations
Yes,
once in a while. So this is a lower dose, and we further reduced it after the
yeah,
procedure. That was the only reason. Otherwise,
yeah. Fair enough.
she would
Because
have been
we
a
change
fantastic.
our, yeah, idealistic is something, and what is practical is something different. So
Yes.
you will, the practically the like Atif and or who is actually managing the person maybe in a better person, but ideal situations we will be doing like this. But the practical is definitely different, and we have to do accordingly. Yes, Atif,
The other
continue.
thing is her falls. So that was one red flag because she started
Yeah,
having falls very early, but they didn't persist. So usually when in Parkinson's, once patients start falling, it'll gradually keep on worsening either in on or off state. But her falls were initial few years, and after that she became fairly stable. And towards the end, she started having falls again. This is like almost into 13 years.
yeah.
So
So before I
actually,
give, yeah,
we evaluated that whether she has some other reason. So her falls were like she used to trip and fall rather than postural imbalance. It was a bit more like spasticity. So we did screen the spinal cord as well to see if there's any compression. So she had a few hemivertebrae in the cervical spine, although there was not much myelopathy when we did the scan. That is almost 10 years later. So that's why we did that. Uh, so we thought it is more because of a little bit of spasticity that she may have had it early on, and she got used to it eventually. Uh, we also did a syndromic search whether she has a ASD, she has hemivertebrae, two hemivertebrae, and early Parkinson's. So one thing that was fitting was something like a Digeorge syndrome, which can present with some early, but she didn't have any hypocalcemia or anything. We've sent genetics also for her, which is not ready yet.
So I just give you asking LRC, I just want to comment is that whenever you find a young onset Parkinson's disease having falls, and which is not because of the postural imbalance, you should always, if especially if it's a lady or somebody, you should see the below knee what is happening. Okay, in my experience, many people actually develop foot dystonia. Okay, sometimes in the on, sometimes in the off state, foot dystonia, dyskinesia, foot related problem like many of the Parkin mutations and all will have a foot related problem which is much troublesome. Even after medications they may fall because of the problem in the gait. So, and sometimes I have seen, not maybe not this in patient, but whenever there is an unexpected falls in these patients, you see the tremor, whether there is a different type of tremor which is coming up in the leg. I have seen a patient of young onset Parkinson's disease. She has a typical rest tremor in the hand that is about 4 hertz. But when you auscultate the leg and it's a one-sided orthostatic, slow orthostatic tremor, the patient has developed with mild dystonia. So many other things can be behind the clothes. Actually, you should properly see these patients below the knee and see when she's walking what happens to the leg. So there are some of the tips which you may like to practice. Yes, Ella.
Thank you, sir. Thank you for bringing up the points of foot dystonia and other issues when the patient is falling, especially early into the illness, in patients who otherwise we think are classical Parkinson's disease. So I have a related question, which was not usually dealt with in the LEDD calculators. So we have this patient on triaxiphenidil 2 milligram 3 times a day. How do you incorporate this into the LEDD calculation?
Okay. This is the thing which we wanted to study, and actually we had done for amantadine versus this. So I don't think we have any straight answer for this. The best way is that if you want to study, you just give this in the off state, give one tablet of 2 milligram pacitin, and later on another day you give 125 milligram or 200 milligram of levodopa and see what is the response and try to calculate it. That is the only thing which I can tell. I don't think there is any often answer is there. We had done a study, but any other person has any answer to that?
So
What is
I
the
just wanted
equivalent?
to ask because there are some studies recently when we were trying to review the literature, I found that what they have mentioned is suppose a particular patient is taking 3 times a day, then you assume that that is equivalent to 1 pill of levodopa. Like for example, if the patient is taking 6 milligram 3 times a day or 2 milligram 3 times a day, both of them are considered to be equivalent to 1 pill. Either it is 2 milligram 3 times a day, then it is 300 milligram equivalent of LEDD, and 6 milligram is also equivalent to 300 milligram. So what they were suggesting is that that particular patient needs 6 milligram to control the tremor or whatever symptom they are targeting with triaxiphenidil, and that is assumed to be 1 pill. And based on that, there are some studies also which have been published, but I agree that it is not a very commonly used form of LEDD calculation, and I think we can work on that as well.
Yeah, I think, yeah.
Yes, sir, nothing.
Mhm. Yeah, you can continue with the presentation maybe.
We'll go ahead, sir. Yes.
Yeah, yeah.
Yes, sir.
One thing will be good documentation of the tremor. As sir
Mhm.
said, lower part of the this thing, why she is falling, why the gait is impaired. Is it just bradykinesia or dystonia, or any other things like biomechanical changes, knee joint problems? We
Yeah.
should have a good documentation with video as well.
So coming back to the presentation,
Okay,
what
just
is
one second. Okay, now I'm just
yes?
telling you this one, which it may be of interest to you. This is the one which we published. A comparison of effectiveness of triaxiphenidine and levodopa on motor symptoms in Parkinson's disease, and this has been published in Journal of Neural Transmission in 2020 December. So there we had actually studied this, and it was published, and we found a lot of things in that. You can just go through that. Maybe Ella, you can see. Okay. So the conclusion was that with triaxiphenidine, the maximum degree of improvement was in the tremor subscore and not significantly different from that obtained by levodopa. So, okay, so some equivalent area we tried to figure out in this study. Yeah, continue.
Yes, sir. So
Yes,
coming to
sir.
the
Sorry, I read that paper. When we were reviewing, I found that paper as well. Thank you.
Okay, thank you.
So coming to the procedure itself, I'll be going through what the procedure is, who an ideal candidate for the procedure is, the anatomical targets for the procedure, and my colleague Dr. Vimal will go through how the workflow of it. So what is it? It's an MR guided focused ultrasound, which is an advanced non-invasive treatment for patients with essential tremor and tremor predominant Parkinson's disease. There are three components of the procedure. The procedure uses high frequency sound waves, which are channeled towards a specific point in the brain. And the MRI offers a real time guidance and observation during the procedure. These ultrasound waves are induce localized heating. They converge onto the targeted brain tissue and induce only localized heating uh, at the proposed target. The intensity and duration of the heat are regulated to form a lesion at the intended site. So, who is an ideal candidate for undergoing this procedure? First is patients with idiopathic Parkinson's disease fulfilling the MDS clinical diagnostic criteria. This includes Parkinsonism, which is bradykinesia with either rigidity or rest tremor, and absence of the absolute exclusion criteria, which includes cerebellar signs, supranuclear gaze palsy, Parkinsonism restricted to lower limbs only for more than 3 years, treatment with anti-dopaminergic agents, absence of response to levodopa, sensory cortical loss. So all of these are absolute exclusion criteria. Um, and at least two supportive criteria with no red flags. The red flags would be rapid deterioration of gait, absence of progression over 5 years, early bulbar and respiratory dysfunction with severe autonomic failure, early recurrent falls, disproportionate antrocholis, absence of non-motor features during 5 years, and pyramidal tract signs. So once the diagnosis of idiopathic Parkinson's is established, the next indication would be to target patients who are refractory, whose tremor is refractory to medications. That is, they either should have a disabling rest or action tremor with inadequate control despite optimized levodopa and other anti-Parkinson medications. And this tremor is causing significant impairment in activities of daily living, as we saw in our first patient. Also, the other indication to do it would be for levodopa responsive motor fluctuations and levodopa induced dyskinesias. So, putting it all together, if the ideal patient to be selected for the procedure, one, looking at the disease itself, it is studied in idiopathic PD with in patients who have good levodopa responsiveness and a disease duration of usually more than 4 to 5 years with a significant disability. Regarding cognitive status, the patient should have normal cognition or mild cognitive impairment with stable mood, and they should have the ability to cooperate through the procedure. With regards to imaging requirements, a skull density ratio of more than 0.4 to 0.45% is required. I'll just come to that in a minute. And generally, they should be able to lie supine for about 2 to 3 hours. Now, this skull density ratio is a pre-op measurement that is derived from a CT scan, and it predicts the patient's eligibility for the procedure. What it essentially is it is a ratio between the radio density of the marrow or the cancellous bone to the cortical bone. The reason this is important is because the procedure itself relies on passing high intensity focused ultrasound through the skull to heat and ablate a specific target. So this skull acts as a significant barrier that can absorb, reflect, or distort the waves. So an SDR of more than zero point 0.4 is typically required to allow sufficient ultrasound energy to pass through the skull and reach the target temperature without the other adverse effects of overheating. Having said that, patients who should preferentially undergo DBS are young patients who are likely to require a long-term adjustment of their of their symptoms, a need for programmable and reversible therapy, and if they have significant bilateral motor symptoms. So who are the patients who are not eligible for the procedure? Patients, I've divided them as color and imaging factors based on their neurological status and their other medical conditions. So based on their skull and imaging factors, if they have a low skull density ratio, they would not be a candidate for this procedure. If they have other MRI contraindications, for example, if they have a pacemaker that is not MRI compatible, if they have severe claustrophobia and the presence of multiple intracranial calcifications, would exclude them from having the procedure. If they have a MoCA of less significant cognitive impairment defined as MoCA of less than 21, if they have intracranial aneurysms, intracerebral AV malformations, and drug-resistant epilepsy. The other medical conditions that exclude them from undergoing this procedure are unstable cardiac arrhythmias, and a relative contraindication is if patients are on anticoagulation therapy. So now that we have seen what it is and who can undergo it, the next question would be where. So these are the FDA approved target sites in movement disorders. Since we're looking at Parkinson's now, for tremor, the VIM nucleus is the target site to address a tremor. Whereas for to address bradykinesia, dyskinesia, and rigidity, the targets are globus GPI and the subthalamic nucleus. And recently, the PTT or the paludothalamic tract is being targeted to address bradykinesia and dyskinesias. For an essential tremor, which is medically refractory, one-sided VIM nucleus is the site of target for essential tremor. In focal dystonias, there are no currently FDA approved, FDA is currently not approved the MR guided focused ultrasound procedure for dystonias. So just a brief recap on the direct and indirect pathways in Parkinson's. In a healthy brain, the substantia nigra, the blue lines are the dopaminergic neurons. The green lines indicate the direct pathway, and the red lines indicate the indirect pathway. So normally, the substantia nigra has dopaminergic projections into the striatum, and via the direct pathway, the striatum inhibits the GPI, which further inhibits the thalamus. This thalamus has a excitatory effect on the motor cortex. We'll just look at the role of the VIM nucleus in tremor, that is the pathophysiology of tremor. Here there is interaction between the basal ganglia cortical circuit and the thalamo-cerebellar circuit, which is encoded in blue. The basal ganglia circuit is encoded in red. So here the thalamus acts more as a relay center for these connections. And by ablating the VIM nucleus, the tremor can be abolished. The role of the paludothalamic tract, we can look at the same same figure. The paludothalamic tract is the connections between the GPI and the thalamus. So in patients who are receiving long-term levodopa therapy, there is altered basal ganglia firing causing over-inhibitory effect of the GPI on the thalamus. So by lesioning the PTT pathways, it'll disinhibit the thalamocortical network, re-establishing the motor control. Hence, in our first patient, she underwent MR-guided focused ultrasound through the left VIM nucleus, and our second patient underwent MR-guided focused ultrasound to the left pallidothalamic tract, because her complaint was a troublesome dyskinesias. Thank you.
Right. Thank you. Thank you, Jennifer. Sir, any questions?
You are muted, sir. So you have to unmute yourself.
Can you hear?
Yes, sir. Yes, sir.
Yeah, I think Atif, you can just ask questions from the audience. Maybe anyone wants to ask anything about these management issues, or you want to tell just briefly guideline what should have been the ideal management in these two patients, and whether any deviation from the ideal you can maybe tell. Is it?
Yes.
I'm
So
having a problem.
anyone has any questions? First, we can deal with those. So there are some questions in the chat.
So I think just one thing, maybe, before going into the first patient, so all depends on the, the center and the availability in India, in Indian context, because people are asking about the Indian context. So in Indian context, any advanced therapy depends on the, first of all, is the availability of that particular, intervention, like HIFUs or apomorphine or DBS or lesional surgery. So availability is first. After that is the accessibility of the patient to that particular center. Okay, whether if it is a DBS, you have to come every time for programming, etc., etc. Then the affordability. So affordability, though I'm telling you, is the last. That is probably the most important question in Indian context, is the affordability. So affordability, then accessibility, then availability, and then
yes.
accessibility also. If a person, I have seen patients whom a patient should be fit for deep brain stimulation. Say 5 years back, there was no HIFUs that time, deep brain stimulation. But that time, a patient was only offered by the doctor a apomorphine pump. So the patient was never aware that a DBS something exists or not. So apomorphine, then after 2 years, the patient got frustrated and then said that I cannot do all these things, and I would have taken DBS. So nothing was discussed with the patient. So we need a counseling for the patient and the caregivers. What are the things which is available? How much is the cost? And after we make our mind that what is the best therapy. So for the first patient, I may say that in ideal situations, okay, the best therapy could be still a deep brain stimulation. But this patient, if it is only on one side, patient is getting in a little, the deep brain stimulation will cost say 25 lakhs. The patient is getting in a much cheaper. Then one-sided thalamotomy is definitely ideal. We have done radio frequency thalamotomy for one particular side, but at no occasion we will do both sides. Any procedure, lesioning procedure, is the absolute taboo, even if it is a high frequency ultrasound or it is a radio frequency. At no point we are going to do bilateral thalamotomy or pyridotomy. This is number one for the first patient. For the second patient, I feel that since the disease is bilateral, okay, and there is rigidity, bradykinesia, tremor, the ideal situation in this particular patient should have been or could have been a deep brain stimulation. Okay, but there are situations where patient has given the option that, okay, deep brain stimulation, we need to open the skull or do a bar hole, and you have to come for constant programming. And but the advantage is that your both bradykinesia, tremor, rigidity all will improve, and it is a both sides procedure, and probably in the long run it will be cheaper. So then we open it for the patients, their wish and their affordability, etc. So these I would have managed like this, but now Atif,
yes, sir.
invite you to give your comments on that.
That's fantastic points up. So basically, uh, the first thing that I would say that from our side, from physician side, the first time when we see, we should not make up our mind that the patient needs which particular therapy. So the first time we see, clear up the diagnosis, manage medications, optimize medications, and start a discussion with the patient. What is the social background? Will they be able to afford? Will they be able to come regularly for follow-up to change settings if you do a DBS? And finally, so in our center, we are lucky that we have all three. So we can provide DBS, we can provide FUS, and as well as RFA. Uh, but finally, which one to choose comes out of patients, multiple discussions with patients, relatives. Uh, uh, that includes, of course, like we did a DBS for one patient, and he's from a very rural area, and for him, he finds it very difficult to come because the bus from that center is only once a day. So these are very small things. Going back, we were wondering whether a lesion would have been a better in that patient. The first patient, we did a lesion more than this thing because her main symptom was tremor, and tremor was not settling with medications. We even tried beta blockers and other, hoping that she'll have some amount of relief. Her bradykinesia was fairly better with levodopa itself. And that's when we started counseling regarding DBS and other advanced treatments. And we had this option of FES which came up. And we tried, if just her tremor comes down, other things we can manage with medications. And that's why we did this thing. The second patient was the ideal patient for DBS. We probably spent a year discussing with her, giving her all options. But she comes from a very poor financial background. So as I was saying, even dopamine medications he gets from the hospital. We had some fund available for which we thought we'll do this off. Now, the only advantage that FUS gives is that repeated follow-ups for current change, adjusting programming may come down, but patients still have to come for medication. So it's not a very big advantage also. The somebody had asked for cost, sorry, accessibility before that. So FUS is a newer, I'm sure eventually it'll become much more popular. But right now it is available only in 4 centers in India, if I'm correct. So Gangaram in Hyderabad, in Coimbatore, and in CMC, and it will eventually come up in AIMS as well. That's I've heard, and eventually it will come up in multiple centers as well. Price is an issue, of course. It currently costs about 8 to 15 lakhs depending on the center. So in our centers around 8 lakhs on one side. So if you have to pay 15 lakhs for both sides, again DBS becomes a more better option. In our center, it's a little bit cheaper, of course. If you have to do one side, it's a good option. So if the only the patient's lifestyle improves with one side treatment, like the tremor of the patient improved, and she's now able to cook, she's able to clean, she's able to go and do some work in the fields, even if there's a tremor on the left side, and she's happy about it. So definitely the other side will not be even thinking about in her. So these are the questions in that we have to discuss with the patient, and we'll be covering that. I think Vimal will be covering some of those points regarding accessibility, uh, availability, and affordability.
Yeah, thank you, Atif. I think, yeah, before Vimal goes, I think he will have a presentation, isn't it? On the
Yes, sir. Yes, sir.
Yeah. Anyone, Ella, any comments you want to give on?
Yeah, sir, I think it was a very well managed case, and I'm sure at the price of 8 lakhs, if the patient is able to go back to work, that is definitely worth it. And if we are able to improve the quality of life, that is the most important thing. That is very good for the patient, and I appreciate the team for doing this wonderful work. But a question that is lingering in the mind is, for example, in the next 2 3 years, if the patient develops significantly disabling symptoms on the other side, then what would be our go-to plan? Do we have a fallback plan?
And one more thing in the extension of this is that if in next 5 years the thalamotomy, the MR-guided
Same side.
thalamotomy, the cost comes down to say 3 lakhs per site, and whether people will venture to do both sides thalamotomy, which is not at all, it is a red flag. It should not be done, never. Okay,
Yes, sir.
because it can cause drastic
Just
problem. So,
gait
what
and
will be the option when if the high frequency ultrasound guided, MR
so,
guided medicine is given?
what people are doing already is if somebody has had a WIM lesion, uh, WIM on the other side cannot definitely be operated. Like we have had the experience from RFA as well. So people choose alternative targets like dental-rubro-thalamic tract or PTT as well. And of course, this goes along with counseling that dysarthria may worsen, gait may worsen. Uh, so again, that discussion is very well. Now, i- of course, Parkinson's disease is a progressive disease. So forget the other side. The same side may worsen in another 3 to 5 years. That data is still not available. But knowing PD, the same side symptoms will also worsen. So there are some people who have done the same side uh, uh, a second time as well. The third thing I would like to say is that if we have done a PTT lesion, for example, parallelothalamic tract for PD, and the patient's symptoms become bilateral or even the same side or and other side, so a DBS can always be done. So an ST and DBS, because it's ahead of the pathway, it can always be done. It's not a complete. So of course, it's a huge financial load to doing one side a WIM and then or a PTT and then going for a DBS later on. But PTT track lesioning after following which DBS theoretically can be done, and I'm sure some patients would have got it done as well.
Yeah, Ella, you want any new question? Your hand is up.
Dr. Atif, I think you are right on track. The disease is expected to progress over time, and especially in the European settings. Like I was with Professor Obiso's team for some time in Madrid, and it is very common practice for them. They are like
Oh,
one of the early adopters. They have been doing the procedure since 2015, and they have like 11 years follow up for patients with Parkinson's disease, and they have a subset of patients in whom after unilateral procedure for Parkinson's disease. A few years down the line, unilateral DBS on the other side has been offered. So in countries where there is public sector funding and
yes,
there is no major financial burden on the patients, these things may be very simple and straightforward. But for resource limited setting like us, I think we need to have that discussion upfront and inform the patient that few years down the line you may need
yes,
another procedure, and you must be prepared for that.
yes.
I think that would
That
be
that
the way.
discussion, and Vimal will be discussing some of those points as well.
So yeah, before just one more point before giving to Vimal. So over time, I think what we should also record is the effect on the non-motor symptoms. Okay, you do bilateral, you do once thalamotomy, and then you do the tracheotomy that side, then you do DBS. As a human being, the patient even after DBS, we see so many new non-motor symptoms starts. The
Yes,
gait problem starts, the freezing problem. The who never had gait problem or balance problem or speech problem before DBS gets that after 5 years. Okay.
yes, sir.
So these we have to follow up closely that whether we are going to make another subset of PD patients which is iatrogenic. I have seen a person I will not mention, a classical Parkinson's disease patient of 5 years duration, one-sided, just more symptoms. A high frequency this was done. Okay. When the patient came to me with a side effect profile, the patient looked like as if the patient has a CBS, nothing else, cortical basal
Oh,
syndrome. Okay. But when you review it, definitely it was not a cortical basal syndrome. It was a totally PD. After that procedure, patient has developed a cortical basal syndrome. So these are the things we should, very carefully document as to the that we have told the patient. Because any type of thalamotomy earlier also, not only RF thalamotomy, we have done plenty. There could be, side effects of hitting a blood vessel, causing a hemiplegia, and exactly the same thing happened. The pyramidal tract got involved in that. So lesioning always is a procedure where we cannot go back. It
go
is not
back.
a one-time thing. So any side effects which can happen can change the classical PD into a Parkinson plus syndrome in these same patients. So I think, yeah, Vimal, I think you want to discuss now.
Yes, sir.
The next, I think we have another half an hour. Yeah.
So Vimal is a neurosurgery resident, junior resident, and he'll be presenting some of the surgical aspects and also some of the social aspects that which procedure to choose and when. Vimal, can you?
Yeah, yes, sir. Good morning, everyone. I am Dr. Vimal Britto, final year resident from the Department of Neurosurgery, CMC Bellu. I'm here to discuss on the surgical aspects of MR-guided focused ultrasound surgery and some social aspects which the patients generally face during the admissions in the hospital and during their follow-ups. So before we go ahead, this is a graph which was published in a journal in Brain. So before knowing about the evolution of functional neurosurgery, these cases which started from Finney's cage, Victor Lebrun, have helped to localize neurologists and neurosurgeons the various lesions in the brain and their areas of localization. So if you look at the graph, by the time of 1980s, there is a dip in the functional surgeries that has been performed on these patients following the invent of the anti-Parkinson drugs. So once these drugs have been constantly used on these patients, and now the patients knowing the adverse effects on all these things, functional surgery has begun to take an upper course where you can see a rise in the number of functional surgeries being performed on these people. So this is how functional surgery, neurosurgery started evoluting from the beginning of thalamotomies and ventriculographies, which was performed using X-ray of the skull, and dyes were injected into the third ventricles, and ACPC lines were calculated, and mid-commercial point was taken as the initial point for all locating these thalamotomies. So when these lobotomies were performed for treating patients, accidental transection of the anterior carotid artery led to the initiation of these thalamotomies. So here I have put a picture of Dr. Irving Cooper, who is the father of functional neurosurgery and cryosurgery, where his ideas have led to so much evolution of functional neurosurgery in the recent times. So these previous surgeries were very crude and the results were inconsistent. The first image which I've shown here is actually image of brain which shows lobotomies being performed on these patients. And the second image is a ablation or performed on these patients, which is still an invasive procedure. And now we have evolved to the point where a targeted lesioning is being performed now. So to precise in a single line, MRGFUS is an energy transmission using phased array transducer. Typically, 1024 electrodes are being used in a closed loop system where MR thermometry is used for constantly monitoring the patient and targeting anatomical lesion and delivering high intensity energy to create coagulative necrosis of the lesion. So my presentation will run in the following topics, which covers physics, basic physics, target selection, stereotactic localization, operative workflow, and technical advantages. So first of all, what is being used in a MRFGS is a normal ultrasound, which uses piezoelectric crystals. Using a high energy ultrasound in the between a range of sub megahertz to low megahertz is used for transmitting energy to the patient. Multiple ultrasound beams are used, which converges heat to a particular focus point. Usually, the heat is converged to a focus point of 1 cross 1 cross 3 centimeters. The focusing of heat in a particular point causes coagulation necrosis. When this heat exceeds the thermal threshold, it causes irreversible damage to the tissues. And this heat is calculated for a particular period of time, beyond which the damage is irreversible. So the most important advantage of this MRGFUS, it is a closed loop system where the patient, two things happens. One, normal MRI is used as MR thermometry. The amount of heat that is being dissipated on the patient is calculated every time, and the patient is constantly monitored throughout the procedure. So, as Jennifer has already told, the most important prerequisite for a patient to get into MRGFUS is a skull density ratio. So, your skull, everybody's skull acts as an acoustic lens which absorbs and refracts ultrasound energy. So, this skull density ratio determines how well an ultrasound can penetrate through the skull. So this formula has already been mentioned, which is an average between the mean Hounsfield unit of a spongy bone to the mean Hounsfield unit of a compact bone. Usually, the skulls with high skull density ratio are usually transparent, which has efficient heat delivery system. And usually, the amount of energy used is very less, and a shorter time interval is needed to ablate the lesion. Whereas, on the other hand, a patient with a low SDR, usually the skull is very dense and a large amount of energy is used for coagulating the lesion. So regarding the imaging, what are the images that we require is the routine images of T1, T2 flare and all other sequences has to be taken in all three views, axial, coronal and sagittal views, and these images are fused together. So MRI is used as an imaging technique for this MRG FUS, has three benefits. One, it is used in target definition, which provides a better visualization of the target. So second thing is the anatomical delineation of the target, because the targets which we are planning to choose in MRG FUS has got very important structures surrounding it. For example, I have shown a picture here. Here the target is the Wim nucleus here. So here you can see the laterally it is a posterior limb of the genu, posterior limb of the internal capsule and the genu here. Here we have got the mammillothalamic tract. So these structures are very adjacent to our target, which is better delineated on a MRI sequence. And this MRI is also used as a thermometry where heat which is dissipated to the patient is constantly monitored, and we can adjust the heat depending on how much energy has to be dissipated on the lesion to cause coagulative necrosis. The same MRI can be used for post-procedure imaging, which confirms whether the lesion has been completely ablated or if the patient develops any sort of symptoms within the during the procedure. The MRI can be used to confirm whether the lesion is correct or the lesion has to be adjusted before the final procedure is done. So here I have mentioned about some evolving sequences which helps in delineating the target in a better way. The first sequence is a white matter nullifying image, which uses magnetic rapid gradient echo sequence. So normal images cannot visualize certain important nucleus, like a Wim nucleus cannot be seen in a normal T1 imaging of a MRI. So this white matter nullifying sequence enhances the contrast of the white matter and the gray matter in a different way. So here the green pointer which shows the mammillothalamic tract and the red pointer shows the dentatorubro-thalamic tract and the white star shows the internal capsule. So your corticospinal tracts pass through this posterior limb of the internal capsule. So this sequence, you can delineate all the gray matter in the brain, which helps in better targeting of the lesion. So this is the other sequence which we usually use in our institution for the procedure. It is a fast gray matter acquisition T1 inversion sequence, commonly called as FGATR. So this sequence helps to strongly specify between the gray matter and the deep nuclear contrast. So here, there is, in my image, I have shown the target as a Wim nucleus here. So in this coronal image, you can see the posterior limb of the internal capsule passing over here, the rubral wing of the thalamus over here. So this here is the target of my point here, which is at a safe distance from the posterior limb of the internal capsule. And the point where I have chosen is well above this interface of the rubral wing. So here are the axial sections where you can see my point lying at a very safe distance of 3.5 millimeter from the target. So other targets which are being used in this FGATR sequences or GP pylotomy is commonly, this sequence is commonly preferred for using GP pylotomy. So one of the most advanced technique is by delineating the tracks, multiple tracks, which runs through the same region of what we are targeting. So the first common method is the four-track tractography. This method is captured by placing seeds within the dentate nucleus, the red nucleus, and the motor fibers. So this seeding of these targets helps to visualize where are the white matters. So here I have shown the image which shows your corticospinal tracts, which divides into both your decussating fibers and your non-decussating fibers, and your medial lemniscus, and the dentatorubral tracts, which has decussated non-decussating fibers. Here, in this image, which is shown below, you can see the indirect targeting. I'll come to both indirect and what is meant by indirect and direct targeting in the subsequent slides. So there are certain coordinates which has been prefixed for the localizing of a lesion in indirect targeting. So in this image, if you see, the yellow circle is our target. So this is a normal imaging which has been done, normal MRI imaging. So here you see the critical structures are in very close proximity to our target, which is planned for lesioning. But here, when I have done a better sequence with all the sequences that has been mentioned above, and with fractography, you can see the yellow target is at a safer distance from my posterior limb of the internal capsule here. So this type of imaging helps to better delineate my targets in a safer way. So there are other techniques which are being used and they are emerging, which involves AI and 18:1 resolution or optimum. These are some of the softwares which are being used for the localization of the lesion. Coming to the targeting, there are two types you can target a lesion. One is an indirect targeting, which has got preformed coordinates, and other is a direct targeting, which is done with the images what I have mentioned above. So, what is an indirect targeting? Here, the key point for an indirect targeting is an anterior commercial line and a posterior commercial line. So what happens here is anterior commercial and the posterior commercial lines are calculated in all three views, your axial, coronal, and the sagittal view. And the mid commercial point is taken as a key point. So here, since our cases, we have involved only BIM, thalamotomy, and PTT. I'm just going to explain about the coordinates which are used for both these lesions. So considering this, as a midline, I mean, this is in an axial view, your anterior commercial point comes here and posterior commercial point comes here. So this will be a midline which connects the both. So my target will be approximately 11 to 14 centimeters lateral to the mid commercial point. And considering the anteroposterior, so lateral means your right to left sequences, and anteroposterior is from the front to back, and vertical is superior to the inferior. So anteroposteriorly, how do you calculate this? It is 5 to 6 millimeters anterior to the PC. So in other words, we can just divide the line which connects the ACPC into 4 quadrants. So it is approximately 25% posterior, I mean anterior to the posterior commercial line. And superior inferior, when we consider, it is usually 1 to 2 millimeters superior to the ACPC line. So this classification, which was done by Hassler, is a highly detailed cytoarchitectonic parcellation scheme, which led to the development of this Schalterbrand and Warren atlas. So this is a foundational mapping which is being extensively used in functional neurosurgery. All these atlases are used for the direct localization of these targets, and all these targets are also based on the ACPC line and your mid-commercial points. So here, since our cases are dealing with my WIM thalamus, I'm starting the direct localization for the WIM thalamus here. So if you look at the picture, the red circle marks the area of my WIM nucleus within the thalamus. So this WIM nucleus is targeted usually for treating of the essential tremors and tremor-dependent Parkinson's disease. It occupies only 0.5 to 2% of the total thalamic volume. So this WIM nucleus is the relay center for the cerebellothalamo-cortical tracts. So any disruption in these tracts will cause improvement in the tremors. So if you look at this image, you can see the posterior limb of the internal capsule here and the VC nucleus, which lies immediately posterior to the WIM nucleus, and ventrovalis nucleus, which lies anterior to it. So next target, which has been mentioned here, is the pyrothalamic tract. So same way, like how we had coordinates for the WIM nucleus, we have coordinates for the pyrothalamic tract, which is usually at a distance of 10 millimeters from the midline. And anteroposteriorly, it is 1 millimeter superior or either, anterior or posterior to the mid-commercial point. And superior inferiorly, it is always 1 millimeter inferior to the ACPC line. One thing we all have to understand is all these targets are vaguely based on a general population which has been calculated before. There are some changes that tend to occur while calculating the targets in doing the procedure. So the other localization, which is a direct localization, once the images are acquired, we generally target the place where we want to focus the ultrasound beams. Here, this you can see, this is the pyrothalamic tract, which was targeted, which lies very close to the mammothalamic tract here. So inferiorly, the subthalamic nuclei lies here. So on targeting the pyrothalamic tract, you have to be cautious because all your important structures lie adjacent to it, and any change in the target to a distance of 1 millimeter can cause serious damage to the surrounding structures. So how do we choose the patients? So we have a multidisciplinary team in our institute, and usually the multidisciplinary team selects whether the patient is a good candidate and which target to treat, and whether MR, FUS, or DBS is an option for these patients. Our core team has a neurosurgeon, a neurologist, a neuroradiologist, an anesthesia person who generally decides on whether the patient is a good candidate and to target what lesion. Everything begins here. So once we confirm the diagnosis and the symptom pattern and medical refractoriness, the MDT begins at that point where our neurologist and neurosurgeon has a meeting and decides what type of treatment is best for the patient. So we have options for all three in our institutes where we perform all DBS and MRGFUS. So there the decision is made what type of treatment is suitable for the patient. So coming to the operative workflow or MRGFUS, it has 4 steps. With the first step is the planning step, which I have already elaborated on the imaging and what type of target is chosen, and all the settings which has to be performed in the instrument which we use here, and the setup which includes setting up of the instrument and getting the patient ready for the procedure, and sonication, which is a workhorse of the MRGFUS, and confirmation, which is the post-procedure imaging. So I think we have already gone through the planning, targeting, and localization of the lesion in the previous slides. So we will go with the setup of the patient and getting the patient ready for the procedure. So usually, since ultrasound waves are dissipated by the hair or the air bubbles which is around the scalp, so we generally prefer a full HA for the patient, which is very safe because it doesn't cause any thermal burns. And then the patient is shifted to an operating room where a scalp block is given. So the images which we have mentioned here, the already like the Epgator images and other sequences are generally fused and are fed to the system. So the next step subsequently which happens is the frame placement. So the stereotatic frame usually has 4 points, 2 points anteriorly and 2 points posteriorly. The 2 points anteriorly are fixed in supraorbital ridge and 2 points are usually fixed in the occipital region just above the transverse sinus. Here, the notable thing here is we are not aligning the frame to any line. So we, in our institute, we prefer aligning the frame to the orbitomeatal line. So it is symmetrical. So all these frames have got pointers, which are usually fitted with the silicone caps. Once the frame is fixed here, a silicone sheet is placed over the scalp and fitted in a watertight way. This silicone sheet is fitted as low as possible in the skull. So once the silicone sheet is fitted, all folds are supposed to be avoided because these folds are capable of generating water bubbles when air is filled through this silicone sheets. So these silicone sheets, once they are fitted into the operating system, is usually filled with the degassed water. And these degassed water is usually a cooled water to a temperature of 16 degrees Celsius. And this is constantly circulating through the scalp. Two principles of physics are being used here. One is acoustic coupling and scalp protection. So acoustic coupling, the ultrasound waves travel very poorly through the air, as we all know. So this cap combines the circulating water acts as an acoustic medium where sound waves can easily pass through. Next is the thermal principle of physics, which is being applied here, where the hair can usually trap air bubbles and absorb the ultrasound waves and allow them to refract them. So once this setting is done to the patient is shifted to the MRI room. On the frame, he is positioned on the MRI gantry and the frame is secured to the helmet. So adequate paddings are placed at the pressure points, and this helmet here, as I have shown, this is a technical image where here will be your the silicone sheet and here will be the system, and this space between the system is filled with filled with water, which prevents air bubbles inside. So next is the operative system. Here is the exhibit system, which is being used in our institute. So this system, as I've shown, this silicone sheet, which is fitted with the patient's head, is connected to the exhibit system here. So this system, the most important feature is a geometrical center. So as we have already discussed, both the patients whom we have targeted or the left-sided lesions. So the geometrical center of this system has to be brought to the left side so that all the heat waves which are supposed to be dissipated are focused at these points. So the points which I have showed here are the various dimensions which helps in adjusting the geometrical center. So one will be for setting up the anteroposterior, and one will be for adjusting the mediolateral, and one will be for adjusting the height of the geometric center here. So once this watertight seal is attached to the system, usually there are the silicone gel that is applied to the system here so that the water doesn't leak through the system, because it might be a cumbersome procedure inside the MRI room to have all these complications. So the patient is inside the gantry room and the images had been fed to the system here. So here you can see the overlapped image of a CT skull and an MRI image, which has been fused together. And here we have chosen the target, which lies here approximately. And here the safety structures have been marked around. So all these systems are pre-operatively planned to decide what is the size of the target and how much energy has to be dissipated and what are the safety structures around and what kind of complications the patient may develop during the procedure. So this is the workhorse of MRG FUS. The most important thing it is a closed loop system which helps to test drive the lesion. So here in the workhorse, we have got 4 stages during the course of the procedure. The first phase is the align phase, during which the target is selected. The second phase is the verification phase, which helps to confirm the targeted lesion is at the point of your focus of energy or not. The third phase is your treatment 2 phase, where you test drive the point of lesion. And the fourth phase is your actual phase, where the lesion is properly ablated. So when you look at the graph, you can see the correlation between the phases and the amount of heat that is generated during each phase. So the first 3 phases are usually reversible phase. As I have already mentioned, usually the coagulation necrosis of the tissues happen when the temperature reaches beyond the threshold. So here, the first 3 phases, we don't cross a threshold of 57 degrees Celsius. Usually, irreversible damage occurs beyond the temperature. So first 3 phases are reversible phases, and the last phase is an irreversible phase. So this is the first phase, aligned phase. Here, the lesion is verified. So here we target the lesion. Once the lesion is targeted, a typical low power is generated. So here you can see the amount of power being generated and the duration for which the power has to be generated. So as we all know, energy is a combination of power and duration. So this is the total amount of energy that is being dissipated to the patient here. So the first phase, where 150 to 300 watts of power is generated for a period of 10 to 20 seconds. So here, the maximum temperature reaches is up to 40 to 45 degrees Celsius, which is still an irreversible phase, still a reversible phase. This phase is neither therapeutic nor adversive. So this phase is usually constantly monitored using a real-time MR thermometry, which confirms the focal point and the amount of energy being delivered. If your focal point is either close to a very critical structure or if it is away from the targeted lesion, you can electronically steer this point during this phase. So the second phase is the verification phase. Here, the power is increased to approximately 400 to 600 watts for a time period of at least 10 to 15 seconds. So the peak temperature recorded here is approximately between 48 to 52 degrees Celsius, still a reversible phase. So this phase constantly stunts the tissues without damaging the tissues. So reversible neuromodulation can also be performed here, because even in this setup, even in this point of time, you can adjust whether the target can be changed or not. So once the lesion is verified, patient is taken out of the gantry room to perform clinical examination. So generally in our institute, we ask the patient to perform an Archimedes circle as the first step, followed by finger nose test, and we also check whether there is any improvement in the rigidity and bradykinesia of the patient. So here is images of the Archimedes circle being performed by the patient during the procedure, pre-procedure, and following the procedure. Here you can see the distorted circles here. This was done before the procedure, and once the verification phase is done, we have asked the patient to draw the Archimedes circle where there is a reduction in the number of tremors during each circle, and this is the post-procedure following the procedures once the procedure is completed. This is a clinical examination that was being performed during the procedure inside the MRI gantry room. Our neurologist checks for the amount of tremors, any improvement in the tremors, and how much rigidity or bradykinesia has improved. You can see the neurologist checking for the any development of weakness in the limbs. So if any adverse effects are encountered during this procedure, the target lesion can be adjusted for a distance of 1 to 1.5 millimeter, and the mapping is repeated. So this is the final phase of MRGFUS, where a phase 3 and phase 4 combines together. So once the lesion is functionally verified and the patient has got excellent tremor reduction, the final phase is carried out. Here, the power is escalated to a core temperature of 54 to 60 degrees Celsius for a time period of 10 to 20 seconds. This is a lethal thermal dose, and this causes irreversible necrosis to the patient. When you look at this image, which is first mentioned here, you can see a light blue circle and a dark blue circle here. So this light blue circle indicates a reversible damage that has happened, and a dark blue circle indicates an irreversible damage, which is a center core point of the target here. So once the first 3 trial runs have been done, so there is a term called cumulative equivalent minutes. So this calculates the amount of heat that has been cumulatively applied over the point of lesion. So this second graph shows a point, commonly termed as cavitation, which indicates the amount of volume that has been lost during the procedure. This graph indicates the correlation between the time period and the volume loss at the point of targeting. So every dip that happens here indicates cavitation, which in turn indicates the amount of loss that has been lost in the procedure. I mean, tissues that has been lost in the procedure. So what it implies is that even after this point, even if you apply so much of energy to it, there will be no use in applying the same target. So once the procedure is completed, the patient is proceeded with the post-procedure imaging, where a T2 image is being acquired here. So here you can see a dry zone appearing in the targeted lesion site here. So once the lesion is confirmed and the targeted site has been damaged, the patient is taken out, frame is removed, and transferred to our ICU for observation. So what do you see in the postoperative imaging? So the characteristic feature which we see here is a trizonal lesion, which contains zone 1, zone 2, and zone 3. Zone 1 is a central necrotic core which appears at the center of the lesion and which usually measures around 1 to 2 millimeter. And the second hyperintense zone here is a cytotoxic rim, which is usually caused by a cellular injury around surrounding the lesion. And the third zone is a vasogenic halo, which causes because of the edema. And this zone 3 usually expands over a period of time. And this zone 3 is responsible for the transient and permanent complications that happens in a patient. So this is an article which was published in Neuroradiology, and this article shows the progression of the lesion from day 1 to first week and then 3 weeks, where the lesion completely disappears. So this during the first week following the procedure, the lesion is very characteristically marked, and you can see the comparative images where the zone 1 significantly grows in size over the past 1 week and disappears at the end of 3 months, whereas the zone 3 is constantly remaining the same, and persistence of zone 3 over a period of time is responsible for the complications that happen in a patient. So coming to the advantages, so first advantage is it is an incision-less procedure, because lots of people coming to our institute ask for a demands an incision-less surgery. So MRGFUS offers a option for them where a patient can go for incision-less procedure, and this is a closed loop and a real-time monitoring where the patient is constantly monitored for the neurological evaluation, and the amount of temperature that is dissipated to the patient is being constantly monitored here. And there is no ionizing radiations here. MRI is a non-ionizing radiation, and ultrasound, which we use here, are non-ionizing radiations. And the recovery is faster. Just once the patient comes out of the MRI gantry, you can see the symptoms being improved in these patients. And the next is submillimetric steering. The point of focus can be adjusted to a distance of 0.5 to 1 millimeter. So this system is useful when DBS is not suited for the patient. Coming to the limitations, it is an irreversible procedure, unlike DBS, where the system can be programmed at various times according to the progression of the disease. So patients who have got head and neck tremors are still not favorable for this MRGFUS. And in patients whom long-term durability is considered, or the program has to be altered, MRGFUS is not an ideal procedure for them since it causes irreversible damage to the lesion. Other is the heat sink effect. Because heat is being dissipated to the surrounding structures, there may be transient damage to the surrounding structures, which can cause complications. And the MRGFUS, which is being targeted now, is mostly focused on the targets that are most commonly centrally oriented, like your WIM nucleus, PTT, everything. So the lesions which are in the periphery are still tougher to be targeted by the MRGFUS, which is being used now. So coming to the complications, we have got three types of complications, which is an intraoperative complication, which is mostly thermal burns and pin site complications, which we encounter in our patients. So the next complication is an acute complication, as I've already mentioned, because of the persistence of the zone 3 vasogenic edema in these patients, these can cause damage to the surrounding structures, causing either a gait ataxia or unbalance if the lesion is more medial, or paresthesia if the target is posterior, or dysarthria or dysphagia. So we have encountered transient complications in our patients, but the incidence of permanent complication is very rare. And these complications usually are encountered between 12 months, 3 to 12 months of post procedure. So here I have run through the MRGFUS, how it has evolved over time from 2016, where it was started as a unilateral thalamotomy procedure. Now, and 2018, it has been started for tremor-dependent Parkinson's disease, to targeting of PTT for bradykinesia in 2021. Now, in 2025, bilateral PTT targeting has been done and tried in patients, and still it is under trial for most of the patients. Both these cases were discussed before about the symptoms and presentations. So the first case was an idiopathic Parkinson's disease, which tremor predominance. So I think we have seen the videos of both these patients here. So here the targeting was the WIM nucleus of the thalamus. So this is the pre-op imaging of the imaging of the patient, and this is the post-procedure. You can see the improvement in the tremors of the right side. Left WIM nucleus was targeted here. Yeah. So this is a second patient who was diagnosed with young onset Parkinson's disease and levodopa-induced tremors. So this was a pre-procedure imaging of the patient, and here the target is a left pyrodothalamic tract. So this is the post-procedure imaging, where you can comparatively see improvement in the bradykinesia of the patient, and these patients had simply significant improvement in the rigidity and tremors. So on elaborating about the outcomes, these are some of the studies which has been performed in the recent years on both essential tremors and Parkinson's disease. So on analyzing these studies, the biggest disadvantage of these MRGFES is there is no long-term outcome that has been analyzed in the subset of population that has been undergoing MRGFES. Only one study, which was done in 2022, has got a 5-year long-term follow-up. That is the maximum long-term follow-up we have ever obtained in our studies. So in all these outcomes, there is at least 40 to 50% improvement in the tremors of these patients, and the complications that has happened is comparatively low when compared to the other treatment modalities here. So this table shows the studies that has been carried out on Parkinson's disease, where the outcome has been very good, at least 80% improvement in the tremors, at least 70% improvement in bradykinesias, and 90% improvement in the rigidities have been reported on these patients. Same as I told already, all these studies are short-term studies, and no long-term data has been available on these patients. So just to concise my presentation, I would like to overview on the various treatment modalities on DBS, RF lesioning, and MRGFES. So invasiveness, comparing DBS is a highly invasive procedure where you have to do a bud hole, you have to insert a neurostimulator, and the periodic programming has to be done, whereas RF lasering is still an invasive procedure and MRGFES is a non-invasive procedure. So the time taken in a DBS to see visible results is approximately 4 to 6 weeks, because DBS is usually adjusted according to the patient's improvement and the patient dependence. Whereas MRGFS and RF lasering, you can see the symptoms being improved immediately once a patient is out of the procedure. So MRI is being used as a common targeting imaging in all these procedures, and the treatment accuracy is the biggest advantage of MRGFS, where the point of target can be adjusted to sub-millimetry, which is approximately 0.5 to 1 mm. Whereas in DBS and RF lesioning, the point of lesioning is quite high when compared to MRGFS. So MRGFS, since the data is not available, we are not sure how much retreatment on the same side is possible in patients who are undergone MRGFS, whereas DBS is always the best suited for programming of the system which is placed already inside. The same adverse effects have been reported in all these patients, the procedure related, which includes hemorrhage and seizure. And one of the biggest disadvantages is infection, which can happen in a DBS patient, or the electrodes can get damaged, or the other complications remain to be the same in all three procedures. Advantages, the most common advantage of DBS is when the patient needs treatment on bilateral sides, DBS is an excellent option. And for a long-term follow-up or keeping the patient in follow-up, DBS is an excellent option still now. So this is one of the newer technologies which is being implemented by MRG FES. So recently they are started targeting pain pathways. Since the central, lateral, the lateral thalamic pain targets are feasible to be targeted, so pain targets are being chosen for the management of pain. So the other thing is the blood-brain opening, where the blood-brain barriers were broken by the ultrasound waves, and chemotherapeutic drugs are being transmitted through these, so that they can have a better efficacy. So the other point is they have started using this MRGFS for liquefaction of high-grade tumors and obtaining a biopsy from these lesions. So the rule of thumb is that the further the target, less amount of energy is required, and it can be used for other purposes. Consolidating my presentation. So all three modalities have their own pros and own cons. So we have already mentioned, if the patient needs a bilateral treatment and on a long-term follow-up, DBS is best suited for the patient. And if the patient requires an incisionless surgery with high surgical comorbidities, MRGFUS will be a good option. And if the patient has got cost restraints as the most important thing, RF ablation will be a best factor for these patients. Thank you.
Thank you, Vimal, for your presentation. Uh, I would like to thank the IAN for inviting us. Actually, this is my first time I have come to this forum. But as Vimal has presented, I just wanted to bring out my points with respect to the multidisciplinary team, which is necessary for management of these kind of diseases. Inputs from neurologists, input from our neuroradiologists, and also our physicists, and the ultrasound technologist is very, very important for these kind of procedures. It is definitely a, a procedure which has to be propagated, since not many people are aware of it. With some people might feel that the point when we are doing the procedure is very boring, but the people who are doing it, the point of ablation is very, very important, and hence imaging and technology is helping us a lot. Imaging already been explained by Vimal, and with the advent of AI, we have not have it here in India as of now, but in the West, they are looking into softwares called the rebrain softwares, which is helping them target lesions with very good efficacy. Having said this, this is a newer technology which requires a lot of research, and even though Dr. Pramod was not willing to do bilateral pallidotomies, FUG has been accepted by FDA for bilateral PTT and WIM targeting. Also, newer treatments for dystonia, writer's cramp, opening up the blood-brain barrier for pain. All these are under research, and this will definitely come up. One of the things we went to Chennai for a patient's meeting. The appeal of an incision-less procedure is going to come up with the patients, even though we are not cutting anything inside the brain over the brain, but inside there will be a lot of thermocoagulation. But since there is no incision, no burr hole, the appeal will be too much for the patients to go for this. So these are the pointers which I needed to give. Any questions which need? I saw one question in which someone had asked, when we hit the dentatorubral tract, can we pick it up? So the procedure is usually done awake, and if the patient, after the verify and the alignment, patient develops some features of ataxia, tremors, or dysmetria, we can steer our lesion a little bit more medial. And with respect to long-term data, Indian population, we still don't have, as Atif has already said, we have only 4 centers in India, and fifth one is coming up. And any other questions, we can answer.
Pal, sir?
Yeah, so I agree with, it is a fantastic presentation. And what Dr. Tony has also told, I agree. But this one point, what you mentioned, that it is not that I do not agree for the bilateral procedures. If given the option, and if the patient wants to know the full facts, as of now, if they want to have an incision-less procedure, definitely bilateral MR guided should be done. But if the patient is willing for, and the patient is suitable for DBS, bilateral DBS is still maybe a better, less side effect producing option than a bilateral as of now of the MR guided high frequency ultrasound. This thing.
Sure.
So yeah.
Right.
Dr.
And
Kelsey?
yeah, Ella, I think wants to speak. Ella?
Yeah, I agree. Vimal, that was an excellent and very holistic and complete presentation. Thank you for giving that presentation and also discussing about the various targeting techniques, including FGATIR, tractography, and other AI-guided methods. So the thing that we need to remember is it is not bilateral PTT, it is staged bilateral palliatothalamic tractotomy, which means that there is a latent period of at least 6 to 9 months between the two procedures. So that being said, I had a query regarding how do you do the targeting, especially when you're doing the palliatothalamic tractotomy, especially for dyskinesias, as we saw in this particular patient. So do you have a specific portion of the PTT, if it is upper limb predominant, lower limb predominant, the medial and lateral PTT? How do you decide how to do that on a case-to-case basis?
Yeah, predominantly it is case to case. We won't call it a dual lesioning, but since we can ablate two medial and the lateral PTT together, so we get a bigger and a wider area of ablation. The medial PTT will be little bit anterior, and the lateral PTT will be little bit superior and posterior. So we try to, when we see the thermography, we try to encompass both of them and try to see the effect. And if the patient is tolerating, we'll go for a larger lesion encompassing both of them. That is what we had done in the recent case.
And in the initial, one of the landmark publications by Professor Obiso's team in NEJM, so they had targeted the dorsolateral STN unilaterally. So any experience with trying to target the motor STN for treatment of PD symptoms?
Not from our side. We have stuck mainly to the PTT and the WIM from our side, and dorsolateral STN FUG. I think it's done in the Europe. I think West is US and all are still not agreeing for that. I think that will require a little bit more studies to come up for clinical practice.
Thank you, sir.
Atif, before we end, there are some questions in the chat box. I think you want
Yes,
to
sir.
answer?
We can go through them, sir. Uh, so one question was, if we have to do genetic testing for YOPD, uh, where can we send and what to ask for? So uh, now across India, I think everywhere there are a lot of private labs, and the cost also has come down. We have an in-house genetic treatment also. So we generally tend to send more of whole exome sequencing nowadays for YOPD. What is your this thing, sir?
Yeah, whole exome sequencing,
Whole exome
and
sequence.
and also with the mitochondrial, I think they give a package
Yes,
10 to 12,000 is not more than that. Yeah,
cost
these
has
are very.
come down dramatically. So whole exome plus mitochondrial in some patients,
But
I
I
think.
again advise that anyone venturing to do a genetic testing, please counsel the
Counsel.
patient and the
Yes,
caregivers what is the implication of that. Okay,
yes,
so without pre-genetic counseling, you should never do a genetic testing unless you are doing for a research purpose. Where again there are two options. Research purpose is not that you cannot. You have to take the consent of the patient and the caregivers, and you may say that I'm not. So it depends on the patient. If this is not paying, it depends on the patient. There are also institutional things that whether you want to know the result or not.
yes.
So you want to know the results, we may have to do again give you the results with an appropriate counseling. And many chance of 70% time you so in a YOPD 80% time you may not get any result. Is number one. In another, whenever you get a result in 80% of the time, you may get VUS or uncertain significance, or you need to do a repeat Sanger sequencing the parents and all these things. The cost will build up. So these are the things which it is just not like a one time thing.
Single test.
And after that, if you get a genetic diagnosis, so after that, what next? So you have to counsel the people whether the relatives are affected or not. All the questions will there. So this is very important that genetic counseling, at least the counseling the doctor should do, not the geneticist, the doctor should do with the patient and the caregivers. Why you should do the testing and what benefit you can get and what benefit you may not get.
More
Yeah, I
than
think
the
LMS you
test
want
being
to.
available, more important is the counseling.
Counseling is very important.
Mm.
Yeah. And even if you are also bound by you get an undetected, non-relevant but pathologically significant genetic diagnosis you may get. Okay, something which is totally out of the blue. So
Yes.
sometimes the cancer genes and all those things. So there again the problem occurs that whether you should inform, you should not inform. There are many guidelines are there, ethical considerations are there. So genetic
Dr.
testing should be taken very seriously before you contemplate.
Dr.
Ella,
Lavarsi?
talk something.
I agree completely that counseling is the most important part. Pre-test counseling and then post-test counseling, both of them are very important for genetics. But that being said, there is another important caveat I think we need to remember in the context of Parkinson's disease. The presence of a genetic mutation does not preclude the patient from
Yes.
undergoing any form of device-assisted therapy. So that should be also conveyed to the patient, because often at times the patients also are sort of demoralized once they uh, find a genetic mutation, and they may therefore, if they are not properly informed, they may not accept a particular treatment that can be very effective for them as well. So that is also something that we need to keep in mind, especially when we're doing genetic testing in the context of planning for MR guided ultrasound or even
Any,
DBS for
in
that
fact,
matter.
any therapy, any test, any variant doesn't change the outcome or not
No,
the
so
outcome.
there are now studies are there. Certain genetic variants of the PD has a surgical genomics that field. Like if you have a GBA mutation pathogenic,
GBA1.
maybe a cognitive decline is the a higher chance later on you may try to do GPI. So there are certain genetic ones which have a favorable outcome, which does not have a favorable outcome. This can be there are the whole field is there of surgical genomics which one will help. Not like a dystonia where monogenic
Yes, sir.
isolated dystonias you
Dystonia is a
get
different.
so
So, okay. Second, DPS versus MRGFS in the second patient. Uh, so, I can answer that. So, for
eh,
the in the second patient, DBS was the prior the discussion wise, DBS was the best treatment which would have been possible. But because it was if patient was not agreeing, not affordable, that's why we went for MRGFUS. There is in that there is no doubt. So we have to lay down clinically which is the best treatment, And then it's a discussion with what the patient wants, what are the requirements, how much the patient can come for follow-up. And of course, the other side, what will be the quality of life with either of the therapies. It's a discussion within patients and physicians. So we have to give all the options, including non-surgical treatments on all the surgical therapy. The one question is there any chance of damaging rubro-thalamic tracts in FUS? So in fact, damaging DRTD is one of the treatment uh, options for tremor. We can target it and uh, do the therapy, of course.
No, I
And
think the question they're
other
asking is
side,
that whether while doing the lesioning surgery, how can we identify that we are damaging the dentatorubral
okay,
tract?
fine.
That is what, I think our clinical examination would tell us if there's any worsening of ataxia or tremors,
Yes,
and then we can steer our lesion a little bit more medial, not to damage the dentatorubral.
yes.
Another question which I hear is read is, are there any studies with DBS guided identifying the sweet spot followed by DBS thermocoagulation? So if I understand this question, probably they're asking whether the DBS target and the thermocoagulation target are the same.
Mm.
So there has been a little bit of disparity in literature about this. Since when we are putting the DBS electrodes, there'll be some four
Lesioning.
electrodes for four electrodes in the STN. However, when you are lesioning with a MRFUG, the lesion will be little bit superior, about 1 or 2 mm superior to your DBS target, since you need to have an area which does not have any side effects, like not close to MTT or the posterior limb of internal capsule. So there will be a little bit of disparity. Probably the DBS guiding system will help you put the electrodes so that the maximum electrodes go into the STN, and you can stimulate it accordingly. However, your lesioning has to be at that particular point, which might be a little bit superior to the regular coordinates which are being described.
Dr. Lavarsi?
Sorry, I am not able to see the question, exact question that they have asked, but is it in relation to the sweet spot analysis? What exactly is the question, sir?
No. So I think the idea that Tony is saying that are both the places where we do a lesioning and we put the contacts same. So what Tony was saying, they are generally not the same, because in DBS we have multiple options of having different contacts. Uh, Whereas in MRGFS you have only one lesion. So even in generally the areas are not same. DBS suites are really completely different, probably, and as a MRG focus ultrasound lesion.
Yeah,
That's the
I
idea
agree
that
that.
I have. It's not like if you have chosen a point for DBS, the same place you can do a focus ultrasound. The targets are slightly different, of course.
I agree completely. I think the question probably what they're trying to ask is, when we are talking about the sweet spot analysis, there are certain softwares that are available in which, depending on the somatotropic organization of the STN, they have studied certain spots that are expected to give better results. And
Oh, okay.
based on some of the commercially available softwares are actually giving AI guided targets. So I'm
Okay.
not sure if the question is related to that, but
Mm.
I agree completely that the targets are not exactly the same, because the direction itself is slightly
Slightly
different.
different,
Because the
yes.
from what I understand, the piezoelectric crystals are placed all across the throughout the part of the helmet, and the ultrasound rays can come from any direction,
Yes.
as compared to DBS electrode, which goes from a I think the target is like the entry point is like 1.5 centimeter from the coronal plane, and there is a particular target that we follow. So both points are not exactly going to be the same, but this sweet spot and sour spot analysis for the target, that is something that is sort of coming up in a big way.
So this is a pre-op assessment, is it? Not
Yes.
intra-op.
No, no.
What do you think?
Preoperatively, when you are assessing, like Vimal rightly said, we use the atlas and we draw the ACPC line and we put a particular target. Or sometimes, if FGATR is available, then you're able to visualize and you're able to make mark it, right? So in
Yes.
that, there is the surgeon's experience that comes into play. The
Yes.
surgeon who has a lot of experience and who has seen several cases, they do the targeting in a particular way, but uh, like for example the Boston Scientific device, they have a particular software, the brain lab, which gives exactly the coordinates where you put it based on various methods. So if you have DTA, you can upload that, and the pre-op planning has also moved in a different direction, especially with the availability of these commercially available AI based tools, image
Yes.
processing and post processing.
Yeah, that's rightly said. There are rebrain softwares which are now coming up in the West, in which they are anatomically mapping out different sections of the brain and the relationship of the lesion with respect to the patient. Now, what has happened is in the West there have been also some studies in which one particular surgeon has gone and done a thalamotomy and patient has not found any improvement or the tremors at record. So when he put those coordinates again through the AI learned rebrain software, he found that his lesion, what he had chosen, was 2 millimeter or somewhat 1 millimeter posterior to what the actual uh, AI learned software had told him. And so he went and ahead and did the second lesioning for this patient, with which the tremors have reduced. So, like these, there are a lot of these anecdotal therapies and observations which are being found, and that's where a lot of research is required for these kind of targeting. And the benefit of using rebrain software, in some cases, you can actually anesthetize the patient and do these lesioning, which they are doing in the West. So these are the upcoming areas which again requires a lot of validation.
I agree, sir. In the team in Madrid, recent publications, I think over the last 3, 4 years by Jose Pinada and team, they have actually sort of studied the STN somatotopy in the context of focused ultrasound. So the whatever surgical knowledge we had in the past was based on MER recordings when DBS was coming up in the 1990s. So that is how the STN localization and the atlas based targeting was done, right? Right now, with the advent of focused ultrasound, they have done studies in which they also have animal studies. So the somatotopy itself is sort of getting redefined as
Correct.
compared to what we had in the past in the context of lesioning. So I'm sure there is a lot of scope for research in this context as well. And with more and more cases being done in India, we will be able to have
Gather more
Indian
data.
specific atlases as well, maybe in the future.
Yeah. Yes.
One
Yes.
question I
Okay.
wanted to ask the neurologist, one observation which has been told to me is that Indian population, the prevalence of essential tremors is lesser than in the West. Why do you think that is there?
Uh, Pramod sir, you want to answer
No, see,
this?
it all depends on who defines essential tremor, whether there is anything existing terminology. So the MDS takes the initiative of defining, redefining, screening the so-called essential tremor, which may be just a mixed bag of just many disorders which cause tremor. So we generally now not harp upon whether diagnosis essential tremor or just an action tremor or a tremor with an underlying cause. So when the tremor is there without an underlying cause, we say it is essential. But now, if you go to the strict definition of the essential tremor, it has to be 3 years. Isolated neck tremor, head tremor cannot be done. Any postural tremor with a little dystonia, anything else will be essential tremor plus.
Plus,
So, if you go into this thing, essential tremor, it is not a less in India.
it is very
Initially,
common.
when I started, I had published actually about 200 patients with essential tremor, that time definition wise, about say 15 years back. The reviewer told that we have never seen in an institute 200 essential tremor. And we had, because of the prevailing, that time, what was the definition? We described the non-motor symptoms first time in essential tremor. So we should not harp upon that as long as we do a lot of investigations and see, because essential tremor runs in families and all, we have never able to find a gene actually. So it is better not to do too much on the nosology, what term we use for that particular tremor.
Tremor.
Sure.
Other thing is
Thank
a lot
you.
of essential
Because
tremor
in a
don't
PD
seek
patients, 40% of the PD patients can have a postural tremor. And the people of PD can have a high chance of
essential tremor.
essential tremor according to the previous classification. So essential tremor, in a epidemiological point of view, people who have essential tremor has a higher chance of developing a PD.
PD.
Okay, as per the old definition. Now, as soon as somebody develops, it becomes an essential tremor plus now.
Right.
The,
Thank you, sir.
the other thing is a lot of essential tremor patients don't seek treatment, milder ones especially, until they it becomes really disruptive. Dr.
One
Larsi?
classical symptom is the alcohol. If it takes, the tremor
Yes.
disappears. Probably that is one of the best things to say that the person has an essential tremor. Okay.
Right.
Dr. Larsi?
Yeah,
The last
I
comment.
agree. I agree with Paul sir that the definition has been changing over time, and they have the tendency of every 3 years creating a new definition and classification. But that being said, the severity of essential tremor, whatever term you want to call it, postural, kinetic, action induced, the point is. I do feel that in India, I don't have a long practice like Paul sir, but with my limited experience, I would say that the severity of essential tremor that we see is nowhere close to what we see in the West. So, during my fellowship days, we used to see patients who have undergone DBS for essential tremor. And when they come for programming, I used to be very scared of even doing the impedance testing, because when we do the impedance testing, the current gradually goes from zero point 0.7 to 1.5. And if the patient is on a 3.5 setting, once we start testing the impedance, the patient starts to shake so vigorously. I have never seen such a sort of violent shaking in any essential tremor in India. Probably there is a phenomenological difference between the West and what we see. Maybe we need to do more studies on that. And Sir Paul sir can tell us more about that front. Have you
I
had any
think
experience of this violent
we
shaking?
we
Yes,
see
yes.
when checking, we see it is not that. Over time you will also see, because you are seeing those patients, so over time they increase actually. It is the and again, essential tremor, the classical old ones, has a bimodal onset. So one is onset is around the age of 20
Younger age.
years, okay, 20 30 years. Another is around the age of 45, 50 to 60 years. So it depends on that. We can take that forum, I think, in another time about these things and data we can collect. Yeah. Yes,
Thank you,
Saraswati.
sir.
Yeah, thank you, sir. A very intellectually enriching session for me at least. So I think we would go on for a day or more with all of you here. But let's close this today. So I am extremely thankful to Professor Parth sir for coming to this session on a Sunday, especially, and
Thank you,
to
sir.
Dr. Atif, Dr. Tony for spending your day today for the Young Neurology Forum. So thank you so much. Thank you to the presenters, Dr. Jennifer, Dr. Vimal, and Dr. Angel for coordinating this. Thank you, Elavarasi, for your comments. As always, you've been supporting us in all our sessions, and I enjoyed all the discussions, and especially this technology which bridges neurology and neurosurgery. I think it is an excellent day for us today. Thank you all. Enjoy next to the Sunday. Thank you so much.
Thank
Bye.
you.
Thank you.
Thank you. Have
Bye.
a good day, all of you. Bye bye.
Bye.
Bye.